there are studies in India that I know. There are lots of studies in the US I know, but of course those are culturally different countries. India is not culturally much different from Indonesia. And those studies have not shown that the propensity or probability of young people or adults going for free sex or increasing the level of sexual experimentation. But there are concerns of elders and elders in all communities that exposing children at an early age to sexual knowledge could or is not advisable in certain countries or in certain regions. But I think from scientific point of view, that public health that we are talking about is also influenced by the opinion of elders. So when we are talking about condom, for example, if the elders have concerns, then we as public health must incorporate their views, because it's the community finally. And condoms then can be shaped closer to those women who have chosen to be in commercial sex or sex working areas, or the clients who are frequenting them. And then you probably want to make sure that you are more sensitive to the needs of the communities, not to just openly start talking about condom or take condom to all occasions. So I agree with what you're saying. Be culturally sensitive, because that's public health. The public health is not only applying a scientific knowledge and get into the community and blow things up. So, yeah? Okay.
Okay, next, Udayana. Udayana, do you have a question?
Yes.
Bali.
Okay, I have one question. Hello?
Yes, absolutely.
Mr. Prof. Subas, you said in one of your slide that in Cambodia they are success in promoting using condom for sexual workers. Almost 96% brothel-based sex worker consistently using condom. Our question is, what is the case success factors of that programs? What makes it different from other countries like in Indonesia?
Yeah, I think there is an intervention that has now been labeled as 100% condom use in sex workers. So I think we will also differentiate, because there was just question about indiscriminately popularizing condom in culturally divergent countries. So what you're looking at is that Cambodia has applied this model in sex workers, in brothel-based sex workers, and motivating them to use condom with every sex worker, and more or less the documentation showed that 96% of sexual activity in these brothel-based sex workers was protected by a condom for a period of 5 years, between 1998 to 2004, and 3 years later they did the national prevalence of HIV through a seroprevalence system of Cambodia, and it showed that from 3.8% it fell to about 0.8%. What it shows is that if you start early in an epidemic, like Indonesia is an early epidemic in most except the Papuas, if you start early and you contain your areas of high risk, not only the sex workers but also the clients, with the use of 100% condom at all the sexual intercourse that happens in the brothels, you really have a real opportunity to reap the best output of the investment in 100% condom settings of brothels and of sex workers. So that's how you wanted more clarity. It is cost efficient and has shown that it works, and it is something that I think is not culturally rejected by most cultures. It is culturally fine that if there are sex worker areas and they use condoms, is good for everybody. Yeah.
Okay, and then next, our site in Salemba, UI Salemba. Do you have question?
Yes, we have a question. Hello, Professor Hira. My name is Rina. In one of your slides, you showed us that there are different HIV subtypes, and we know that HIV is able to mutate. Now, my question is, what is the impact of this situation to ARV treatment in the future globally? And then the second question is, you showed us a model of reducing HIV transmission among sex workers in Kenya. Can you also give us information how effective other prevention models are, such as PMTCT or harm reduction? Thank you very much.
Okay. Yeah, I think we've got two questions. One question you asked about is the antiretroviral drugs and how this mutation, constant drift of the envelope proteins of the virus and occurrence of recombinant forms will affect the future of antiretrovirals. Now, the answer is the mutation itself is not a major threat. It's a major threat to developing an effective preventable vaccine or a therapeutic vaccine. But as far as antiretroviral drugs are concerned, the drugs are basically working on the stable components of the virus, which is the pol and the GAG proteins, not the envelope proteins. So the antiretroviral drugs, they work on the stable genes of the GAG and the pol, and not the envelope, which is all the time changing. So it will not have major effect in terms of the utility of antiretroviral drugs. What might happen is, irrespective of the mutation of the virus, the inadequate or inappropriate use of antiretroviral drugs could lead to resistance in the virus, development of resistant genes in certain loops of the virus, because the individual has not been consistent with the medication, has not been adherent to at least 95% of the pills per week, and so on and so forth. So in that case, I think I've clarified the two things, that let's not be worried about the mutation as far as ARV is concerned, because ARVs work on the stable portion that doesn't mutate. Only the envelope mutates. And the second is that the real risk is that if these antiretroviral drugs are not monitored well, and then I think we'll come in the next lecture somewhere we are going to talk about, if we are not monitoring them well because we think that we do not have CD4 enumerators, or we cannot simplify CD4 technology to monitor them or do the viral load, I as a public health person, don't believe that the science has become so lost that this huge potential of scientists cannot find how to simplify a CD4 testing or how to simplify a viral load testing in our villages. I don't believe this, because I did patent one of the CD4 technologies myself, which is on a simplified glass slide. So I think it's somewhere there where we have lost our determination to do things. Otherwise, I think we have enough scientists, we have enough people, we have good institutions to do it. And public health institutions that I see now on the screen, they are phenomenally good. I think I'm very pleased that I'm talking to you all.
Okay, thank you, Prof. Hira. And the last side is UI Depok. Do you have question, UI Depok?
Yes, I have one question. Okay. We do know that condom have a high efficiency reducing HIV transmission. But as we know, in Indonesia, we do more promote male condoms than female condoms. And in fact, that men have high resistance using condom. Any policy that we do more promote female condoms reducing this transmission? Thank you.
Yeah, I think you're right. There are both pros and cons with both of them. But now, since the female condom is available, it is available in Indonesia through the government systems of delivery for sex work areas, because that is the area where there is so much of vulnerability and risk is there. But obviously, I think some point in time, if there are other populations that really need to use them, even for the sake of contraception, I think it's something that is now available. We all have to make sure that people know that this does exist, so the end users know, and the groups of, maybe there are groups of women associations that would know. There are very literate women who want to protect themselves from unwanted pregnancies. So yeah, that's fine. And I think it's an effort that we should all make, using it in culturally sensitive environments and groups. So if there are married couples and want to use it as contraception, I think that probably is okay in most environments. So yes, I think we should promote it. We should make sure that information is available to all the people, and that's our job, public health. Yeah.
All right. So this is the end of the session 3. So let's give applause to Professor Hira.
Thank you. Thank
you. Okay. Okay, we have run out of time, 15 minutes from the schedule, and let's move on to the next session. So we'll invite Pak Pandu and Pak Iwan Aryawan. Thank you.
Okay.
Excuse me. Hi, can you hear me?
Yes.
I'm from Malaysia. Sorry, I'm from Malaysia. I just want to know the time difference because I'm trying to organize the time. We seem to be on a different time zone. So what time is it in Jakarta now?
It's 10:30.
Yeah.
10:30. Okay.
Yeah.
The sessions actually start at 10 or 9 or
9 Jakarta time.
or 9 a.m. Jakarta time. Okay, now it's 10:30. Thank you very much.
What's the time there, ma'am?
The time is 11:30.
Oh, so you're 1 hour ahead. Okay. Great. Thanks. Well,
Okay, I'll wait for the next session. Wow, 9 to 10.
Okay, let's Okay, let's continue with our next session because we are already run out of time. So the next session will be HIV/AIDS epidemic situation in the Asian region and some country-specific issue in the region. And the speaker will be Dr. Pandu Riono. And Dr. Pandu is a faculty staff of the Faculty of Public Health, University of Indonesia. He is a medical doctor, graduated from University of Indonesia. Then he received his master from University of Pittsburgh, USA. And then he received a PhD in HIV/AIDS epidemiology from University of California in Los Angeles. Dr. Pandu is expert in the quantitative epidemiology related to infectious disease, and he worked a lot with the HIV and AIDS in Indonesia and in the Asia region. He is already working in AIDS since 1990, so Pak Pandu already have a long history in working with HIV and AIDS. Okay, let's continue with Dr. Pandu lecture. Dr. Pandu, please.
Okay, thank you very much. And I will talk about the HIV epidemic situations in Asia, in some countries, but not all countries, but mostly because of the...
I can't hear you all.
Okay. Can you hear
Yes,
now?
Yes,
Okay,
I can.
thank you.
Thank you.
Okay, thank you. And I would like to talk about the HIV/AIDS epidemic situation in Asia, in some country, but maybe some example is come from Indonesia. We knew that Dr. Subas is actually already mentioned that the HIV is not easy to transmit. But even that, we have a look at the epidemic is going and grow up in every regions, and there's no country there's never report about HIV epidemic. In Asia, especially, it's different. That's why it's different. It's not the same with Africa, and also because of the transmissions in Asia is more complex than in Africa. What drives this epidemic in Asia actually is related with drug, injecting drug use, sex works, men sex with men, even marital sex also contribute also the epidemic, extramarital and premarital sex, and the mother-to-child transmissions. And most of this is we can see that the 2 month is contaminated. That 2 month is the main driver of epidemic is sharing contaminated needles among IDUs and unprotected multiple sex behavior. This is the main mode transmission is Asia. And we knew that this Asia, all the Asia, including India, Vietnam, Cambodia, and some country is very diverse. It's very diverse because even they have 2 behavior related to sex and drugs, but the magnitude is different. And we can see also the growth, the trend. Since 1990, we see the transmission is the more the dark of the color is grow up. It means that currently epidemic in Asia still growing up. It's not yet finished or not yet mature. Even that we can see in some area still already declining. This is the example of the trends in Asia. People living in HIV/AIDS, they're the same with the picture that already presented by Professor Subas, that from 1990 until 2007, we see a lot of grow up the people living with HIV/AIDS. It means that if we want to prevent the epidemic, we should prevent the new infections. This is already infected. and still continue that will be distribute or transmit. Two more difference, drugs and sex. We can see different behaviors also produce different trends, because among drug user is easily transmit because blood to blood. We can see they will grow up faster, and then suddenly they will something like saturated or then declining, because many drugs people also infected with another like hepatitis C and hepatitis B, and some of those also dying earlier. But different with that, sex transmissions will be very slow and then continue growing up to until some peak graphic that will be continue. We don't know until when. This is the number. This is the estimated number that already presented. This is example from Indonesia. If we want to prevent the epidemic on the transmission, we should go to the people who has some behavior that high risk. We cannot promote HIV/AIDS to all the people because this is not yet generalized epidemic. Like in Indonesia, the IDU, we have only 200,000, and half of them has partner, have wife. And sex workers is only 200, around 200,000. But the clients is 3 million. It means that we should also go to the male, to the man who has high risk behavior, not only go to the female sex workers. Because half of the client also have wife. This is, we always forgot that the network of transmissions is to be important to prevent, like to prevent mother to baby. We should to prevent to the male first, and then male to not only male, and then their wife before they continue transmit to their baby. And the MSM is around 700. It means that this group will become more important in the next year or the next future in the Asia region, because the HIV prevalence is now grow up among men sex with men. Now we should understand that the epidemic in Asia is more complex. Not only female sex worker to the clients, but also some of female sex worker also have client that drug user. And maybe sex workers have multiple high risk behavior, not sell sex, but also inject or using drugs. This is important because in Vietnam, why in Vietnam prevalence among sex workers is very high, because many of female sex workers also inject drugs, and mean that they share needle, and mean that the female sex worker is more tend to be infected, and then the transmission to the clients. And MSM, men sex with men, also important. Some of them also not only sex with men, but also visit sex worker. And some of them also using drugs or sex with drug user. And many of MSM in Asia, including Indonesia, has wife or have sex with female. It means that even male sex with men become important because they become a bridge to their female clients. This is important because we knew that the dynamic of epidemic in Asia is not easy, not only sex with men, female and men, but also they are related each other. And in here, if we want to prevent the new infection among, If we want to prevent newborn infection, we should go to here. If you go in here, it's too late. It's too late. We should also working in here before they infect to the female partner and then to newborn baby. Okay. This is the trends of HIV prevalence among subpopulation in Indonesia. We can see that in drug user in the red line is now around 50% of drug user in Jakarta. In some area, Surabaya and Bandung, half of them is already infected with HIV. And transgender now become the second high prevalence, is around 22%. And female sex worker is become the third of the trends will be follow after transgender. It means that in Indonesia itself, most of the HIV prevalence is still growing up. Now is the Papua. Papua is the part of Indonesia, they said that Papua is different with the other part of the country because the prevalence among the group is very high compared to the other part of Indonesia. And the data, behavior surveillance survey in Papua in 2007 show that multiple sex partner is the main mode of HIV transmission in Papua. Even that is, we can still, not all Papua have the same hotspot for the behavior because there are some different. We can see the variability of the Papua. We can see in here, a man is higher, almost 2 times compared to the woman, I mean. It means that 3% among adult male, already infected in Papua. And woman is only 1.9%. It means that male is still become more important issue in the for high risk group in Papua. And many people say that because the sex industry maybe influence the epidemic, it means that it should be epidemic should be in the city or in the lowlands. But actually, the epidemic or the higher prevalence among people is not tend to be like that. We can see in the lowland difficulty, we have a higher prevalence and compared to higher lands, in the highlands. But in the city or the lowland EC area is only 1.8, in highland 2.9, like in the mountain area, and is in the very difficult area that we cannot reach by boat or by car is 3.2%. And that's true that behavior among people is influenced, even influenced by ethnicity. It means that we can see in Papua is higher, 2 times that people non-Papua ethnicity, even they living in Papua. It means that some behavior difference also influence based on the ethnicity that also reflect in the HIV prevalence in Papua itself. This is why we should understand. People tend to say that Papua epidemic is like Africa epidemic. Actually, it's not. It's a difference. Asia epidemic is not the same with Africa epidemic, even in Papua. Why? Because of the transmissions is still behavior in the multiple sex partners is still dominated by men. Women's only 7% who has multiple sex partner. It means that we never, or we very difficult to reach the epidemic in generalized because all the transmission will stop to the woman. if the women have multiple sex partner, it means that transmission is still going on. They will stop to themselves or transmit to their child. It means that why in Asia is not will be different with the Africa, because the behavior of women is not the same with the behavior of men. We should say thank you to the behavior of women. That's why, because the HIV will stop in themselves, in the women, or to the baby, because their behavior is very small to have multiple sex partner. Now in the future, we should look at another epidemic that we can already look at in Asia. Especially, we can see men sex with men, like in Cambodia already 14%, in Beijing 0.6%, in Shanghai 1.7%, and in Thailand is 10%, in Jakarta it around 8%. In here, it means that epidemic in the future will go to the MSM if we don't have a good program and still denial about men sex with men behavior. Maybe the growing epidemic will be become more important in Asia. Still, we should have still promote condom, because in men sex with men, not only working with they have sex with men, but also working with sex with the female, and the condom still important for this kind of behavior beside lubricant. The more important is also because here the percentage of condom use still very low. Here is the blue one. If they sex with male sex worker, only 39% in India, people MSM, men sex women, using condom. If not using in the department, not male sex workers, increasing become 50%. With female sex worker, they tend to be higher. This is the difference. Partner, they have different behavior of using condom. Actually, in here, with their male sex worker should have higher the same with female sex worker. Like in Indonesia, we have also the difference condom use among MSM based on their partner. It means that some issue or some misperceptions among MSM when they use condom. Actually, for every partner, they should using high condom. This is the picture, the HIV epidemic in Asia. Even in Asia, two main modes, drugs and sex, but we can see every country has different patterns of epidemic. Even within country, the epidemic also very differs. It means that the epidemic should understand the local epidemic in Asia. Even in Asia, should be Java and Bali or Sumatra is different epidemic. It means that there's no one solution for all. And epidemic, especially now, is epidemic in Indonesia and Vietnam is still grow and become more diverse because the behavior is very complex. And even that, we can see the HIV prevalence in some countries in Asia like Thailand, Cambodia, and in Myanmar is so declining because of the condom use or some prevention efforts among sex industry, that's especially sex in the brothel area. It means that in the brothel area, we can promote 100% condom with different type of strategy that they can contribute declining of HIV prevalence that contribute by sex industry. It means that we can see from Huras-Baras condom promotion is more important because drugs and sex is more complex. There's only condom can prevent the transmissions among this high-risk group. High-risk group using condom, or they change their behavior. If you want to see more information, more graphic, more data, more behavior, just go to the aidsdatahub.org. That's the website that developed by UNICEF and some ADB working with ADB. There's a lot of data you can download. For Indonesia,